Starting off with Lordotic Chest. Lordotic Chest is not an exam we do often, and it's usually after 2 views of the chest have been performed and they see something, usually in the area of the apices on the P or AP chest, and they want to send them back for a specific view that removes sort of the clavicles out of the way of the apex, and they can see it better. So the main focus of Lordotic Chest is the lung apices. And our number one reason that we do it is usually tuberculosis. Also, sometimes it could be for masses or nodules, but number one and textbook wise would be for TB. As far as methods, textbook method would be to have the patient stand about a foot away from the wall bucky here, your image receptor, and they lean backwards, putting kind of the backs of their shoulders against the board, but keeping their hips forward. This is pictured down here as a seated version of that. And then you could keep the tube straight. You do have to watch out for their chin dipping down here into the apices, but depending on your patient's ability. And I'll show you how to do it on a patient who can't do this, but it's the same as chest x-ray. So you're gonna center to T7, you're gonna center down mid-sagittal plane, top of imaging plate, you want at least like 2 inches above the imager's their shoulders, so you can see your triangle of light here because your focus is the apices. So you want to make sure and go a little bit higher. And again, it's on inspiration, just like chest. You're going to photo time as normal. There can be some modifications to this depending on what the patient can do. If the patient can lean back at that severe angle as you saw in the other pictures, then you don't really need an angle. If they can't lean back at all, you're gonna have to angle pretty significantly, so closer to this 25 to 30 degrees angle. If they can lean about 15, you can match them with a 15 angle. In general, it's a 15 to 30 degree cephalic tube angle, so you're gonna angle up towards the head if you need to use an angle. You're still at 72 inches, you're still gonna watch for the triangle of light, but watch your marker, because you're doing it AP, and normally you do chest PA, so just watch for that you make sure your marker is on the correct side. If they're supine, again, more of that severe angle, at least 15 to 20, depending on what you have available, and also if they're a kyphotic patient, so if they have a curvature to their back and their chin is tipped down, you're going to need a more significant angle on that. What you're going to see, so it's going to look distorted from your normal chest, but that's what we want. You can see the clavicles are raised really high up over these apices, and that's the goal. Image evaluation is really similar to that of PHS, so you're going to look for your SC joints, and are they equidistant, but they need to be projected over the lung apices. If they're still in the lung apices, you need to angle up more. All right. TB, or tuberculosis, is something that we'll see often in a chest that then requires a lordotic view. So you might see different markings or these patchy areas higher up in the chest. And then, so we would do a lordotic view. Can you see how the clavicles are shifted way up over the apices, and you can see the apices clearly. This patient here, where this arrow is pointing, if you can see this rounded area in the lungs here, that they want to look out further. So it's kind of near the clavicle. So they took this image, and also this black arrow over here is pointing to an additional rounded sort of area that's not normal. They then came in and did a lordotic view, kicking the clavicles up high, so they could see it in sort of another way. And you can really see this rounded portion here because the angle of the tube, it actually modifies it as well. So they're able to see different areas with the clavicles out of the way. This is another example here. So the white arrows are pointing to sort of an area of concern, and they did a lordotic view here to kind of move the clavicles out of the way. Again, it's not one that we do a lot. Something I want you guys to do for me this week is to review your chest anatomy, both PA and lateral. Okay, review those for me. The divisions of the chest anatomy, so start going through bony thorax, respiratory system, and know what the mediastinum is. space between the lungs. What's involved in the bony thorax? Review sternum, find the parts of the sternum as we go through here, clavicle, scapula, how many pairs of ribs, thoracic vertebrae, we're going to hit that further on in the semester. Positioning landmarks, I know we've done some of these already, but these are one of the things I really would love for you to master and memorize, have a flashcard for. You're going to use these throughout your entire time for positioning courses, so review those for me. Expiration, inspiration, understanding how the diaphragm moves in each of them versus, which way it moves for inspiration versus expiration. And then again, just a reminder, you guys already know this from chest x-ray, but how to determine your degree of inspiration. Did the patient take a good deep breath in? How do you know? Ideally, you count at least 10 ribs, the posterior ribs here that are going more horizontally. The anterior ribs come at this angle here across, so the flatter one, the posterior ribs. And I'm going to stop there and come back to clavicle.